In today's video, we will discuss about vitamin B12 supplementation. It is one of the commonest vitamin deficiency which we see in clinical practice, where the individual will be presenting with either hematological features like anemia or neurological features like tingling sensation, memory related issues, and even imbalance. We all will have some general idea related to vitamin B12, like we will be supplementing with 1500 2000 micrograms of injections or oral supplementations. We will be following daily injection protocol. We will advise for weekly injections, but the exact cutoff we will not be knowing, and in particular which form to prefer. There are numerous B12 forms such as methylcobalamin, cyanocobalamin. So all these things are there. Being the most common deficiency, we have to be very thorough at basics related to vitamin B12. So that we will discuss in today's video. First thing to understand is various units of measurement related to B12. For a healthy individual, every day, very minimum quantity of B12 is required. So the recommended dietary allowance for a healthy adult is just 2.4 microgram. This is the first thing. It is not even in milligrams, 2.4 microgram. But if you observe in the supplements, either oral or in injection forms, we will be giving in 1000 ranges. So why such huge difference when the requirement is very minimum? Why we are supplementing with such huge dosage? That point also is very important. So in case of standard over-the-counter supplements, we will see 500 to 1000 microgram, or you can consider 1 milligram. So here it is in milligram, but the daily requirement of an healthy individual will be in micrograms. And also in case of severe deficiency, we will be supplementing with even higher dosage like 2000 or 2500 microgram. So just for the comparison, the daily dietary requirement is very minimum, that is 2.4 microgram. That is required for baseline survival maintenance. Whereas the standard supplements which will be available in the market will contain minimum of 500 microgram. It is for general wellness, and in case of mild deficiency, we can utilize that dose. But in case of the malabsorption disorders, we have to prefer quite higher therapeutic dosage of about 1000 microgram. Also, when the bodily stores are exhausted and there are severe deficiency features in an individual, we have to supplement with quite higher dosage of 2000 to 2500 microgram. So just now I mentioned that in case of malabsorption disorders like an elderly individual of more than 50 years or the one who is taking metformin, otherwise in case of pernicious anemia. So in all these conditions, there will be poor absorption of the B12 through gut. So in that case, we will be advising for about 1000 microgram of supplement. Why is it like that? Because when we load with such huge dosage, even though there is no active absorption because of any of these disorders, there will be tiny fraction of about 1% which will get passively diffused through the intestinal walls into the bloodstream. So this strategy we are utilizing. So we are just overloading the intestinal walls with quite a huge dosage, so that at least about 1% of that loaded dose will be seeping through the gut barrier into the bloodstream, even in case of disorders related to absorption. So what are those disorders? Just to remind again, age more than 50 years, because they will be facing decreased gastric acid secretion, which is essential for B12 absorption. Also, diabetic people who are on metformin. In case of pernicious anemia, I hope you know about this point. This is an autoimmune disorder where there will be autoantibodies against intrinsic factor or parietal cells. So these antibodies will be hindering absorption of B12, leading to anemia. Then any individual who has undergone gastric surgeries. So these are the individuals where we see the malabsorption of B12. So in that case, ideally we have to prefer parenteral routes, but if the individual is not ready for injections, we can go ahead with the huge dosage of oral supplementation. Coming to the comparison between laboratory readings and the supplementary readings. If you know, the lab results will be mentioned in picograms per ml units, whereas as we discussed, the supplementation will be usually in the microgram range. And the normal value ranges from 200 to 900. Here the point is, if the value comes to be less than 200, below 200, we can consider it as B12 deficiency. But if it is even in the range of 200 to 300, always consider this individual as in the borderline for deficiency. So we have to be monitoring such individuals. This is first point. The second one is regarding the value where sometimes we see more than 1000 or more than 2000 picogram per ml report. So what might be the reason for such high lab values? There will be two possibilities again. One is recent administration of B12. So that might give such huge values, or in case of some pathologies like liver disease or kidney disease. In these, especially in liver disease, even though there is deficiency, we might see B12 levels in the normal range or sometimes even higher. Why? Because the hepatocyte will be getting lysed. So because of cellular lysis, we can call it as hepatolysis. In case of some alcoholic hepatitis or some other hepatitis, we will see spillage of B12 into the bloodstream from the storage, that is hepatocytes, leading to falsely normal or falsely higher values. Similarly, as B12 is a water soluble vitamin, if there is improper excretion of the B12, in case of kidney disease, there might be excessive accumulation leading to higher values. So these two possibilities we have to keep in mind. Similarly, as I mentioned earlier, if the values are below 200 or in the range of lower cutoff, there might be some clinical features which is being asked commonly during Viva are mainly macrocytic anemia. So the individual will be feeling fatigue, and some neurological features, mainly tingling and numbness, as well as there might be some imbalance, especially on closure of eyes. And the commonest features which will be asked in relation to B12 deficiency are why there will be knuckle hyperpigmentation and why we see red beefy tongue, which are considered as the hallmark of B12 deficiency. Here, regarding knuckle hyperpigmentation, we know that B12 is required for DNA synthesis. So in epithelial cells of skin, if there is B12 deficiency, that will also lead to depletion of the glutathione stores. And this glutathione will be controlling an enzyme, that is tyrosinase enzyme, in a negative pattern. So it will be inhibiting that enzyme. And why that enzyme is required? For the synthesis of melanin in a normal individual. So in case of B12 deficiency, when the glutathione stores are also reduced, this enzyme will be uninhibited. So it will be overacting, leading to excessive production of the melanin, causing the hyperpigmentation, as well as there will be effect in the transport of these melanin. So both the synthesis as well as the transport mechanisms are involved, leading to knuckle hyperpigmentation. This is the commonest explained mechanism for this particular finding. Whereas for red beefy tongue in case of B12 deficiency, again here what happens is the rapidly dividing mucosal cells of the tongue will not be able to undergo cell division because of again B12 deficiency causing impairment of DNA synthesis. So in that case what happens, the protective papillae layer will not be formed, which will lead to exposure of the underlying vasculature. So first of all, the papillae will not be there. That's why that rough appearance of the tongue will be lost, and the exposure of underlying vasculature will give a red appearance, red beefy appearance. And especially when the individual takes some spicy food, because of the close proximity of the vasculature, they will feel the excess spicy sensation again will lead to red beefy tongue. So these are some explanations for the typical findings in B12. And the final thing regarding the assessment of B12 levels is, as I mentioned, in some disorders like liver disease, and kidney disease, there might be falsely normal values. So how to identify the actual B12 deficiency? We have to look for methyl malonyl CoA levels. MMA levels will help us in identification of the actual B12 deficiency. So once we identify the individual as having B12 deficiency, how to replenish that? So there are two phases. Phase 1 will be loading therapy. Phase 2 is about the maintenance therapy. In loading therapy, again we will be giving high doses of vitamin B12 to replenish the bodily stores. Whereas once the stores are stabilized, then to keep that stable level, we will be supplementing with the maintenance therapy. So what we can do in the loading phase is, we can choose either parenteral route or oral supplementation. So in case of parenteral route, commonly intramuscular injections will be preferred with a regimen of about 1000 microgram injected every alternate day for about 2 weeks. So what is the mechanism? It will bypass stomach completely, entering the bloodstream directly. So this mechanism will be helpful when there is some absorption related problems like pernicious anemia, Crohn's disease, and even when in case of severe deficiency, we have to replenish the stores as fast as possible. So in case of severe deficiency, or if there are some neurological symptoms, do not wait for the oral method to replenish the stores, which will take quite a longer time. But suppose the individual is intolerant to injections, or if you feel it is a mild to moderate deficiency of B12, in that case we can choose high dose oral supplements, where usually the regimen followed will be 1000 to 2000 microgram daily supplementation for several weeks till the symptoms improve. So the mechanism I have already explained, that is 1% passive diffusion. So once the baseline number is recovered, what we have to do for maintenance therapy is, either we have to advise dietary supplementations, or if the individual is actually facing malabsorption disorders, then dietary supplementation will not help. So even for maintenance, we need to give high oral dosage or interval based injection supplementation. So when it comes to diet related deficiency, which will commonly happen in vegans or vegetarians, it is not an absorption related problem, but the individual is not taking B12 in the diet. So in that case, we can advise for some of the foods, especially fortified foods. Nowadays, B12 fortification in multiple food sources is available. Those things we can advise. Or if the individual is able to take dairy products, they are very good source of B12, we can say. It might be milk, curd, paneer, etc. can be advised. And if the individual is ready to take egg, that is one of the best source we can say, especially the whole egg. 1 to 2 whole eggs daily will give the daily requirement of B12, that is about 2.4 micrograms. And as we know, the major sources of B12 is related to non-vegetarian foods like chicken and especially fish. So these are some dietary sources we can say. And when it comes to malabsorption, where the individual cannot absorb the food through gut, even if we supplement through some dietary source or with some low dosage. So in that case, as I mentioned, either daily oral high dose supplementation can be followed, or for those individuals, we can just say to take B12 injections once in every 2 to 3 months, which will be helpful for the maintenance therapy. When it comes to supplementation of B12, we know that there are various forms available like cyanocobalamin or methylcobalamin or hydroxycobalamin. So the mainly cobalt is the major core to which various groups are being attached. When it comes to cyanocobalamin, don't consider it as a toxic form, because whatever the cyanide which is being attached in this molecule is non-harmful to the human body. When we compare all these things, so what are the features we have to know so that we can choose the right form of B12. When it comes to methylcobalamin, it is the naturally available form and it is highly active, whereas cyanocobalamin is a synthetic form. So what is the usage of this active form? It will be ready to use and it will be readily absorbed and utilized by the body, whereas cyanocobalamin needs conversion to active form in the body. But this active form or ready to use form of methylcobalamin will get degraded in the light, so the shelf life will be very lesser for methylcobalamin. Whereas the cyanocobalamin is highly stable when it comes to shelf life. That's why it is the synthetic form and commonly utilized form in case of supplement formulations. And also it is cost effective. Whereas the benefits of methylcobalamin is as it is ready to be used form in case of neurological manifestations or brain related manifestations like even reversible dementia and all. There we should not wait for all these mechanisms of conversion to active form and all. Directly we have to choose the active methylcobalamin form. And these all are available in capsule forms as well as sublingual forms and even available in fortified foods and syrups. The one more form of B12 which we have to know about is hydroxycobalamin. Again, it is a natural form and the stability is quite moderate and easier to convert in the body, and it is commonly available in the injection forms. So these three are the commonly utilized forms of vitamin B12. And when it comes to the clinical utility, we often see two injections commonly utilized, that is optineuron and Vitcofol. I just want to tell few points about these two formulations. Optineuron, as the name indicates, it is optimum for neuronal health. So what does it mean? When the individual is having B12 deficiency, mainly presenting with neurological symptoms, we have to choose optineuron form because it will have thiamine, B1, niacinamide, B3, B6 as well as B12, but this B12 is in the cyanocobalamin form. Why they have synthesized in this form is because of its better shelf life and the stability, but it needs conversion to the active form. So this point also should be remembered. Whereas Vitcofol mainly has B12 in cyanocobalamin form again plus folic acid B9. So this form is used in case of B12 or folate related anemia. So when it comes to hematological health, Vitcofol is helpful. When it comes to neurological health, optineuron should be utilized. Again, it is not a rule, but just the basic concept to choose the right form of B12 injection. So how to tailor the treatment according to the need of individual is, when the individual is a vegetarian, just for the maintenance sake, because the individual is already having healthy stomach and effective conversion capacity, we can go ahead with the cost effective formulation, that is cyanocobalamin. But if the individual is above 50 years or if there is heavy deficiency of B12, as the age advances, there will be reduced stomach acid and intrinsic factor and all. So it is harder to break down the synthetic products. So in that case, always prefer methylcobalamin form. And also in case of neuropathy features, choose the active form, that is methylcobalamin in high dosages. So in summary, always know the units of B12. So the daily dietary requirement will be in the microgram, whereas the laboratory values will be in the picograms, and the normal ranges we have to know. Then when there is deficiency, two things should be followed. One is loading dose, then the maintenance dose. So this loading dose help us in the replenishment of bodily stores. So once the level reaches normal values, then we can advise for maintenance dose either as the interval injections or daily high oral dose of B12 supplementation. And ideally, this loading dose we can follow alternate day injection regimen, alternate days for about 2 to 4 weeks in general, or till the individual feels better when it comes to their symptoms. Otherwise, till the levels normalizes, we can give it as loading dose. Then do not forget to give maintenance dose. And when choosing the molecule, always look for the formulation. Like cyanocobalamin will be cheaper, so helpful for dietary maintenance in healthy adults. Whereas the methylcobalamin is the active form which does not need conversion in the body. So if the individual is aged or having some digestion related issues, or in case of severe deficiency with neurological manifestations, go ahead with the methylcobalamin form. So I hope you have understood the much needed basics related to vitamin B12 supplementation. Onwards, look for the unit of measurement and see whether there are deficiency features or the individual just needs the maintenance therapy. And once there is deficiency features, decide what is causing deficiency, whether the individual is not taking B12 in the diet or having some issues related to the absorption of B12. Based on these factors, we will decide the route of administration of supplements, either oral or parenteral. And in both the routes, we will always focus upon the composition of the formulation, like whether it is cyanocobalamin, hydroxycobalamin or methylcobalamin. According to the patient's factors, again we will decide which form to be used in which patient. I hope all these concepts are very much clear to you. If you have any doubts, mention it in the comment section. And if you find this video helpful, please share among all your batchmates and the practitioners, because this B12 deficiency is very common and we have to know every basic detail about this. See you in another such clinically informative video. Till then, take care. Thank you so much.